Welcome back to the deep dive. Our goal is always to take complex, source-heavy topics, distill them down to their essence, and serve you up the key knowledge you need to be truly well-informed.
Mm.
Today, we've been handed an exceptional professional source, a deep dive into surgical care advancements, detailing what has been consistently called the most transformative development in perioperative science in the last 3 decades.
And that's enhanced recovery after surgery, or ERS.
Exactly, ERAS.
And that statement, that it's the most transformative development, it's really not hyperbole.
It sounds like it, but you're saying it's true.
It absolutely is. What we're discussing here is a complete philosophical and operational overhaul of how surgical patients are managed. It's a move away from, well, comfort and tradition and toward rigorous, hard science.
So our mission in this deep dive is to unpack exactly how ERAs fundamentally shifted surgical recovery. We're looking at how a field that relied for decades on clinical dogma is now strictly adherent to these evidence-based multimodal protocols.
And we can ground the entire philosophy in one core, powerful insight.
What's that?
Postoperative outcomes improve dramatically when clinicians make protecting organ function and aggressively blunting the body's massive physiological stress response to surgery, their primary non-negotiable focus.
That's the game changer. So if you're preparing for a major operation or you just want to understand the modern revolution in hospital care, you really need to understand ERS. Because when you look at the old model, it was full of practices that just weren't evidence-based.
Not evidence-based, but often actively harmful.
Right.
You were talking about practices that were accepted for generations just because that's the way we've always done it.
Like what? Give us some examples.
Well, think about prolonged preoperative fasting. Patients often prohibited from eating or drinking for 12 hours, sometimes more.
Of course, NPO after midnight.
Exactly. Or think about the historical reliance on heavy opioid analgesia.
Yeah.
Sure, it made patients comfortable, but it also impaired their entire systemic recovery. And then there was the delayed oral feeding and the mandatory prolonged bed rest, immobility.
And the evidence now shows that those old traditions, the fasting, the high narcotics, the delayed feeding, the immobility, they weren't just passively failing to help.
No, they actively injured the patient's ability to recover. They prolonged that stress response we talked about.
So we're going to spend the next 30-plus minutes walking through the science that replaced all of these norms. But let's start at the beginning with the philosophical revolution.
Right.
Where did this all begin?
Well, as we mentioned, ERAS is profoundly philosophical. It's not just a collection of instructions. It required the surgical community to accept that many deeply entrenched traditions, some of which were, frankly, more about surgeon comfort or hospital convenience than patient benefit,
Needed to be thrown out.
instantly. The core philosophy is replacing those old dogmas with highly standardized, evidence-based, patient-centered pathways that are always multimodal.
Okay, that concept, multimodal, that's central here. We need to clarify what that means. When we're talking about fixing a patient's post-op recovery, why is it so important to view the problem through a multimodal lens instead of just looking for one single solution?
Because the body's response to major surgery it's systemic, it's comprehensive,
It affects everything.
everything. The trauma of the incision, the inflammatory process, the fluid shifts, these don't just affect the wound. They affect the lungs, the gut, the cardiovascular system, the endocrine system. So no single drug, no perfect incision, no one technique can possibly be sufficient to eliminate that complex cascade of postoperative complications.
So multimodal means?
It means a coordinated symphony of dozens of small interventions, all working together additively to support every organ system at the same time.
And the history of this foundational shift is tied directly to one pioneering figure, right? The Danish surgeon Henrik Kellet.
That's the one.
Where did his journey start in challenging these established norms?
So this all began back in the 1990s. Kellet introduced what he initially called fast-track surgery. He looked at the traditional approach and just found it completely wanting. It failed to account for the holistic systemic damage that the surgical trauma and, maybe more importantly, the care practices themselves inflicted on the body.
He realized the care was part of the problem.
He realized that the very practices meant to keep the patient safe were actually fueling this destructive physiological stress response.
So his revolutionary thesis, the core insight that really changed the game, was this realization that you couldn't rely on a single fix.
Right. He argued forcefully that only coordinated, comprehensive, multimodal interventions could achieve the kind of dramatic reduction in complications he was looking for. He wasn't just interested in cutting the hospital stay.
Which is what fast track kind of implies.
It does. But he was really interested in accelerating the return of functional capacity. He wanted the patient walking, eating, and living normally as quickly and safely as possible. His work was the first to systematically apply this layered, comprehensive approach.
And he proved this thesis pretty dramatically in his early work. The source material highlights one stunning, almost unbelievable outcome from his early trials in elective sigmoid resection, a major abdominal operation.
He was able to achieve a postoperative hospital stay of just 48 hours.
48 hours.
Just think about the gravity of that number. In the mid-90s, the standard stay for that same procedure might be 7 to 10 days, maybe longer.
Wow.
Kelly demonstrated that by implementing these coordinated stress-blunting strategies, a patient could be safely ready to go home 2 days after major colon surgery.
Yeah.
This immediate, powerful impact just proves that the status quo was fundamentally flawed.
That sounds incredible and revolutionary, but I have to imagine the critics must have immediately worried about safety.
Oh, absolutely.
Wasn't the worry that he was just discharging patients too soon? You know, the sicker and quicker argument.
That was the immediate and persistent criticism. But Collette's counterargument, which was backed by his data, was that patients weren't being discharged early, they were recovering faster.
A crucial distinction.
A huge one. He showed that by avoiding the pitfalls of the old model, like the immobility and the heavy narcotics, the patient's physiological trajectory was just accelerated. What's more, keeping a patient in the hospital longer than necessary actually increases their risk of complications.
Like hospital-acquired infections.
Exactly, or delirium, deep vein thrombosis. He showed that the 48-hour discharge wasn't about cost-cutting, it was a measurable outcome of superior, safer care.
That's the definition of a paradigm shift right there. Now, fast-track surgery was the starting point, but for this to scale globally, it needed structure, refinement, and standardization.
Exactly. Kellett's success was localized. It needed to become reproducible everywhere. So in the early 2000s, researchers like Fearon and Runquist took his foundational ideas and started to formalize them. They formed what later became the ERAS study group.
And that led to a big milestone.
A massive one. In 2005, they published the first evidence-based consensus guidelines, specifically for colonic surgery. That was the moment it shifted from being an expert-driven method to a globally standardized, documented, and evidence-supported pathway.
And the structure of the movement was really cemented in 2010 with the formation of the ERA Society. This seems like the crucial step that transformed a successful concept into a global healthcare movement.
It was. The society contributed 3 elements that were critical for its longevity and consistency.
Okay, what were they?
First, they recognized that while the core philosophy was universal, the specifics needed to be adapted. So they developed specialty-specific guidelines. They differentiated the pathway for, say, liver surgery versus gynecologic surgery.
That's smart. The details matter. What were the other 2 critical contributions?
Second, and this is really the engine of the entire movement, they established the ERAS Interactive Audit System.
An audit system, what does that do?
It's a mechanism for hospitals all over the world to input their data, benchmark their outcomes against global standards, and track their own compliance with the protocols. It lets them identify exactly where their system is breaking down.
So the audit system transforms ERAS from just a guideline into an enforced quality control system. It forces hospitals to prove they're following the evidence consistently.
Precisely. Without this constant measurement and feedback loop, compliance inevitably drops, and then the outcomes suffer. The audit is what enforces the philosophical shift toward evidence.
And the third element?
And third, they created the infrastructure for education and training, transforming it into a cohesive global academic and clinical force.
And this whole infrastructure is why ERS has spread so rapidly. Where are we today with it?
Today, it's implemented across more than 25 countries and has expanded to cover a vast array of surgical fields. It started with gastrointestinal surgery, but now includes hepatobiliary, pancreatic, gynecologic, bariatric, and even increasingly complex areas like transplant surgery. It's now widely considered the modern blueprint for surgical care globally.
Proving that a standardized, audited, evidence-based approach is just better than relying on individual surgeon preference or old habits.
Much better.
Okay, so let's turn to the mechanics. The success of ERAS is built on standardization, the fact that every single intervention is intentional and contributes additively to recovery. For the learner trying to grasp the scope of this, what are the foundational components, the core pillars that define an ERS protocol?
We can break it down into 7 foundational components that span the whole journey, from pre-admission all the way to post-discharge.
Okay, let's hear them.
Number one is structured preoperative counseling, optimization, and really robust patient engagement. Two is the maximum use of minimally invasive surgical or MIS techniques whenever it's technically feasible.
Makes sense.
Three is aggressive early mobilization, getting patients moving on the day of surgery. Four, rapid early intake of oral fluids and solids, completely reversing that old dogma of fasting.
That's a big one.
It is. Five is early removal of unnecessary hardware, so surgical drains, urinary catheters, IV lines. Six is the strategic, comprehensive use of opioid-sparing multimodal analgesia.
And the last one.
And finally, number 7, the non-negotiable requirement of continuous regular audit cycles executed by multidisciplinary teams.
Looking at that list, I can see how mobilization and feeding fit the narrative of faster recovery. But let's focus on that first pillar, preoperative optimization and counseling. The source material insists this isn't just an administrative box to check, but a therapeutic intervention. Why is that pre-op phase so much more than a formality?
Because in this model, preparation is treatment. We're trying to achieve something that's sometimes called prehabilitation.
Prehabilitation.
Right. The preparation is delivered by a multidisciplinary team. The surgeon, nurses, anesthesiologists, physical therapists, and it tackles multiple variables before the operation even begins. The goal is to get the patient into the best possible physiological state to withstand the trauma of surgery.
So what specific content is covered in this counseling that makes it, therapeutic?
It's highly detailed. Patients and their caregivers get procedure-specific education on exactly what's going to happen and, importantly, why. They learn the exact expectations for the return to function, the diet they'll follow, the required mobility milestones.
So they know what's coming.
Exactly. And they might be coached on lifestyle optimization steps, smoking cessation, alcohol reduction, aerobic conditioning if there's time. Critically, we identify and optimize chronic conditions like anemia or poorly controlled diabetes. We turn weeks of preparation into proactive healing.
So it's managing expectations while also preparing the body physically and psychologically.
Exactly. This detailed process serves two critical functions that address that core problem, blunting the stress response.
What are they?
First, the education directly reduces patient anxiety. Anxiety fuels the release of cortisol and adrenaline, which are key components of that physiological stress cascade, ERAS, is designed to fight. So by reducing fear and uncertainty, we are chemically calming the patient before the incision is even made.
And the second function?
It dramatically enhances patient adherence. When patients understand the why they need to walk 3 meters or why they need to drink that carbohydrate drink pre-opper, they become active participants.
Partners in their own recovery.
Yes, exactly. And that leads to much better compliance and much better outcomes. Patient buy-in is absolutely essential. You can't mobilize an uncooperative patient.
Let's move to the operating room itself. The second cornerstone is the maximum use of minimally invasive surgery, MIS. We all know MIS is generally preferred, but why is it a mandatory cornerstone of the ERAS strategy? Is recovery not possible without it?
Oh, recovery is possible without it for sure. But MIS is a massive accelerator of the recovery trajectory, and ERAS protocols mandate its use whenever it's technically safe and feasible. The reason is simple. Minimally invasive surgery dramatically reduces the surgical trauma.
And that trauma is the initial trigger for the whole destructive stress response.
It's the starting gun. When you have a massive open incision, you trigger this huge inflammatory cascade. MIS uses small keyhole incisions, which minimizes the amount of tissue disruption. This leads to less pain, which means less reliance on heavy narcotics.
It's a domino effect.
It really is. It also minimizes wound complications, which are a huge source of post-op morbidity. And crucially for ERA's goals, the reduced trauma naturally facilitates a much faster return of bowel function. And because the patient is in less pain, mobilization is much, much easier and safer. It aligns every single step of the process with the recovery goals.
Okay, so let's follow the patient hour by hour through the timeline, because this is where the old surgical dogmas are explicitly reversed and replaced with these highly actionable steps. Let's start with the revolutionary change that happens even before the patient enters the OR, the reversal of prolonged fasting.
This is probably the most visible break from tradition for patients. For decades, they were starved NPO after midnight to prevent aspiration risk. But the ERAS evidence showed that prolonged fasting, often 12 to 14 hours, does serious physiological harm.
What kind of harm?
It leads to insulin resistance. It increases catabolism.
What's catabolism?
It's the breakdown of muscle tissue for energy, and it causes significant thirst and discomfort. which again increases anxiety.
So what does ERAS mandate now to address that?
The protocol mandates a sharp reduction in the fasting window. We're often talking down to 2 hours for clear liquids and 6 hours for solids. And crucially, up to 2 hours before surgery, the patient is often given a carbohydrate-rich drink.
Why is that so important?
That carbohydrate loading is critical. It prevents that harmful catabolic state, it maintains glycogen stores, and it minimizes the surgical-induced insulin resistance. It basically makes the patient metabolically stronger for the operation. It sounds minor, but it's a huge shift in physiological management.
Okay, and what about fluid management during and after the procedure? I understand in the old model, fluids were given pretty liberally to maintain blood pressure, but ERAS is restrictive. Why is that?
Yes, the old philosophy was often, the solution to pollution is dilution, just liberal intravenous fluids. ERAS mandates something called goal-directed fluid therapy, or GDFT, which is very precise and very restrictive.
How restrictive?
We restrict C fluids to minimal volumes intraoperatively, often just 1 to 2 milliliters per kilogram per hour of balanced crystalloids, and we get those IV drips out as quickly as possible postoperatively.
Why is fluid restriction an enhancement for recovery? That seems a little counterintuitive.
It does, but excessive IV fluid, while it seems benign, is highly detrimental to surgical recovery. When you flood the patient with liberal IV fluids, that extra water leaks out of the blood vessels and pools in the tissues. It's a condition called interstitial edema.
Swelling.
Right, swelling everywhere.
Yeah.
And this swelling impairs oxygen delivery to the tissues. It increases surgical site tension, complicates wound healing, and critically, it slows down gut motility. Restrictive fluid management is a key enabler for faster gut function and therefore earlier mobilization.
And that untethering from the IV pole leads directly to the next intervention, early mobilization. You mentioned earlier that ERAS has a specific actionable definition for this.
It does, absolutely. Early mobilization is not just, sitting up in a chair. It's defined as ambulation at least 3 meters or walking for 2 minutes. And it has to happen on the day of surgery, or at the absolute latest, by postoperative day 1. This is a physiological necessity, not just a friendly suggestion.
What are the deep physiological benefits that make this movement so critical?
The benefits are profound and immediate. First, it actively reduces pulmonary complications like atelectasis and pneumonia because it keeps the lungs expanded. Second, it reduces the risk of DVT, deep vein thrombosis, or blood clots by keeping circulation moving.
And for the patient's morale.
It accelerates the return of overall functional capacity. The patient feels like a person again, sooner. And finally, it serves as a self-auditing tool. If a patient can't safely ambulate, it's a huge red flag that an intervention, like pain control or their fluid balance, is failing.
But getting a surgical patient to walk hours after a major procedure must require perfect coordination. It must be dependent on every other pillar succeeding.
It is the ultimate test of the system. Mobilization requires truly effective, good analgesia so the patient can move without debilitating pain. It requires minimal lines and tubes, thanks to that fluid restriction and early hardware removal. And it requires that proactive patient preparedness we discussed earlier. All the pieces have to work together perfectly for the patient to achieve this crucial milestone.
Which brings us to perhaps the most critical component enabling all of this, the imperative of opioid-sparing analgesia. Now, beyond the public health crisis surrounding opioids, in ERAS context, this is all about the recovery trajectory. Why must opioids be limited in the perioperative setting?
In the context of ERAS, opioids are the enemy of recovery. The list of negative consequences directly impairs our functional goals. The primary issue is the gut. Opioids significantly delay gut function, causing and prolonging what's called an ileus.
A paralysis of the bowel.
A temporary paralysis of the bowel, yeah. And that's a major factor in extended hospital stays.
What other systems are impaired?
Well, they depress respiration, increasing the risk of pneumonia, especially in older patients or those with pre-existing lung conditions. They are the #1 driver of PONV, or postoperative nausea and vomiting, which makes early eating impossible.
And mentally.
They cause heavy sedation and delirium, which prevents early mobilization and contributes to patient falls. Every single one of those effects fights directly against the core goals of ERAS.
So, if we need to provide superior pain control without relying heavily on opioids, what is the specific multimodal strategy that takes their place?
The multimodal strategy leverages non-opioid drugs and regional techniques at the same time. You're blocking different mechanisms of pain perception, a concept called synergistic analgesia.
What does that include?
It commonly includes scheduled doses of NSAIDs, So nonsteroidal anti-inflammatory drugs like ibuprofen or toradol paracetamol, which is acetaminophen, and other centrally acting non-opioid pain relievers.
And what about regionally?
Regionally, we use local anesthetic blocks. This might mean infiltrating the surgical site with long-acting anesthetics or using nerve blocks like a transverse abdominis plane or a tap block, which numbs the nerves going to the abdominal wall. In really complex cases, we use epidurals. The goal is superior, consistent pain control while minimizing or even eliminating opioid exposure, protecting those critical recovery trajectories.
This all sounds like the anesthesiologist is no longer just the person who manages sleep. Their role is absolutely central to ERAS' success.
Absolutely. The anesthesiologist has been elevated to the architect of perioperative physiology within the ERAS pathway. Their accountability extends far, far beyond the operating room itself.
So what are their key contributions that go beyond standard intraoperative care?
Well, they're critical in the preoperative risk assessment, using the time before surgery to optimize existing comorbidities like chronic hypertension or heart failure. They lead the implementation of those opioid-sparing strategies we just discussed, often designing the specific regional block regimen for the patient.
And the fluids.
They are solely responsible for managing goal-directed fluid therapy and making sure the patient does not leave the OR overloaded with fluid. And critically, they often hold key leadership roles in the compliance and audit loops, ensuring the pathway is followed consistently by the surgical and nursing teams.
You highlighted one specific mechanism insight related to the anesthesiologist's work, the physiological benefit of an epidural in open surgery. For the learner, can you expand on that? What's the precise mechanism beyond just blocking pain that makes an epidural so beneficial here?
The benefit goes deep into the endocrine system. Major open abdominal surgery triggers a massive neuroendocrine stress response. The body just floods itself with stress hormones, cortisol, catecholamines, which kicks off what we call the catabolic hormonal cascades.
Okay, let's unpack that technical term, catabolic hormonal cascades.
Think of it this way. These are internal signals that tell the body you are gravely injured. Stop all non-essential functions and start breaking down muscle and fat for emergency fuel.
That sounds bad for healing.
It is. This leads to muscle wasting and, crucially, massive insulin resistance, which makes it very difficult for cells to take up glucose. This state significantly impairs healing.
So how does the epidural stop this?
By providing superior regional anesthesia during major open surgery, the epidural blockade actively reduces this entire cascade. It keeps the nervous system calm, preventing the stress signal from ever reaching the endocrine glands. By managing these fundamental physiological responses, the epidural directly reduces overall postoperative morbidity. It offers a layer of systemic protection that simple, systemic narcotics just cannot match.
It's clear that the core principles, early feeding, early mobilization, opioid sparing, are robust. But what really proves the flexibility and the detailed nature of ERAS is how these principles are adapted for maximum effect across different surgical fields. It's not just a standardized checklist, is it?
Not at all. It's a system tailored to the specific physiological stresses of the operation. That's the genius of the ERA Society. They develop these highly detailed, specialty-specific guidelines to anticipate the unique challenges and high-risk complications of any given operation.
So let's look at that tailoring. Let's start with the area where it all began, colorectal surgery.
Right.
What are the unique tweaks for colorectal procedures, particularly in the pre-op and immediate post-op phase?
The pre-op phase heavily emphasizes that carbohydrate loading we discussed allowed up to 2 to 3 hours before surgery to maintain metabolic balance. We also see a much more judicious use of mechanical bowel prep.
So it's not required for every single case anymore?
No. Which again challenges a long-held tradition that often left patients dehydrated and uncomfortable before the procedure even started.
And what changes happen inside the OR and immediately after?
Intraoperatively and postoperatively, there's a really strict adherence to avoiding routine hardware. This means the specific avoidance of routine surgical drains and nasogastric tubes unless a clear complication requires them.
Why is that so important?
Because tubes and drains cause discomfort, they impede patient mobility, and they serve as potential pathways for infection. Removing the urinary catheter early is also absolutely critical.
Let's discuss that early hardware removal. How specific is that timing, especially in a high-risk case?
It is highly specific. For a low rectal anastomosis where the bowel is reconnected very low down near the pelvis, there's a risk of urinary dysfunction. Yet, the ERAS protocol still mandates early removal, typically within 72 hours, to promote mobilization and minimize catheter-associated UTIs. It's a calculated balance of risk and benefit.
And you mentioned a memorable, almost counterintuitive detail used to kickstart gut function after colorectal surgery.
Yes, the use of chewing gum.
Chewing gum.
Chewing gum. It mimics the act of eating. Specifically, it stimulates the cephalic vagal reflex pathway, which causes the release of digestive hormones and saliva. This simple process stimulates gut peristalsis and mucosal function, and is proven to help reduce postoperative ileus. It can shave several hours off the time it takes for the gut to wake up.
That's a perfect example of a simple, evidence-based intervention.
It is.
Now let's look at high-volume, complex procedures like gastrectomy and bariatric surgery. How are the principles adapted when the primary digestive anatomy has been significantly altered?
Here, the immediate postoperative dietary goals become extremely critical and fast-paced. We need that early gut stimulation, but we have to balance it with safety. This means clear liquids within 6 hours of surgery, progressing rapidly to a soft diet by postoperative day 1 or 2.
That's fast.
It is. It places immediate, safe emphasis on using the digestive tract.
What additional safety measures are prioritized here, given the inherent risk of leaks in these upper GI procedures?
Safety is paramount. First, strict glycemic control is maintained throughout, using insulin drips if necessary, because high blood sugar impairs healing and increases infection risk dramatically. They still have mandatory early mobilization and respiratory physiotherapy. They avoid routine drains, but the major difference is the intense vigilance required for two critical signs of a developing leak.
Which are?
Sustained, unexplained tachycardia, a high heart rate, and localized abdominal pain that is out of proportion to what you'd expect. Tachycardia is often the very first sign of sepsis, and it's treated as a clinical emergency until a leak is ruled out.
Okay. Now, when we move into the domain of hepatobiliary and pancreatic surgery, so liver, gallbladder, and pancreas, the complexity and potential for specific devastating complications rise significantly.
This requires the highest degree of tailoring.
What are the key adaptations for this highly specialized, technically challenging area?
The nutritional focus is even stronger here. Because these patients are often dealing with cancer and severe illness, we prioritize early enteral nutrition, especially in cases where the patient might be malnourished before the operation. We have to ensure their body has the protein and energy required for liver regeneration and wound healing.
What about post-op management, especially around complications? The source mentions some highly specific acronyms.
Yes, post-op monitoring is intense. We want early drain removal, but we need specific, careful monitoring protocols for leaks. For liver resections, we need vigilance for PHLF, or post-hepatectomy liver failure.
And what's the consequence of PHLF?
PHLF is a devastating complication where the remaining liver volume just isn't sufficient to sustain the body's metabolic demands. ERAS ensures rapid identification and intervention if specific liver function lab markers start to deteriorate. Similarly, after pancreatic surgery, we monitor closely for PPH, post-pancreatectomy hemorrhage, which can be catastrophic.
And the greatest challenge in pancreatic surgery is preventing a pancreatic fistula, right? Where digestive juices leak into the abdomen. How does ERS approach that specific risk?
This is a perfect example of detailed ERS tailoring. Pancreatic fistula is prevented through a combination of techniques. First, during surgery, surgeons may use certain techniques at the surgical site. Second, post-operatively, patients receive specific interventions like somatostatin analogs.
What does the somatostatin analog do?
It's a drug that reduces pancreatic secretions. It essentially puts the pancreas to sleep for a few days. By reducing the volume and activity of those highly corrosive pancreatic juices, you minimize the chance of a leak turning into a dangerous fistula. And third, drain management is meticulously handled based on amylase levels. If the fluid coming out of the drain is high in amylase, meaning it's active pancreatic juice, that drain stays in until the levels drop, confirming it's safe to pull. Every decision is based on biochemical evidence, not just the clock.
Finally, the source material touched on transplantation. Given the immense complexity, the need for immunosuppression, and the patient profiles, often critically ill, is ERAS truly feasible here?
It's the final frontier for ERAS, really. And yes, it is proving to be feasible, though adoption has been slower. These patients are often much sicker than standard elective surgery patients and require lifelong immunosuppression, which complicates healing.
But it's working.
The data confirms that applying the ERAS framework, especially focused on early mobilization, aggressive infection prevention, and superior pain control, is a safe and cost-effective method. By getting these incredibly vulnerable patients out of the hospital and mobile faster, you dramatically reduce their exposure to hospital-acquired infections and accelerate their return to function.
We've painted this picture of a successful, evidence-driven system that drastically improves outcomes. Yet the source material made it clear that implementing ERAs is often difficult. It requires cultural transformation, not just updating a checklist. If the benefits are so clear, why is there so much friction and resistance to adoption?
The resistance comes from demanding systemic cultural change, which is always hard in established environments like surgical departments.
What are the major barriers?
The first and most immediate challenge is just resistance to change among long-standing surgical teams. Clinicians who were trained under the old dogmas, who believe they achieved good outcomes by sticking to their routine fasting, delayed feeding, they often find it deeply unsettling to abandon traditions they've practiced for decades.
Even when presented with compelling data.
Even then, it's professional inertia, combined with a fear of the unknown. They might be thinking, what if the old way, which felt safer, was actually better?
And that inertia isn't just with surgeons, right?
Oh no, it's with nurses who are used to keeping patients quiet in bed, or with anesthesiologists who are just comfortable using opioids for pain control. It's across the board.
What about from the patient's side? If they're told they'll recover faster, surely they'd advocate for it.
You'd think so, but there is often patient and caregiver uncertainty. If a patient's relative recovered from a similar surgery 20 years ago and was in the hospital for 10 days, hearing that their loved one has to start eating and walking 6 hours after a major operation can feel, well, counterintuitive or even scary.
It sounds reckless.
It can. It requires immense trust and excellent preoperative education to overcome that fear.
And institutionally, what limits the spread?
Institutionally, there are significant resource limitations. Implementing ERAS requires dedicated staffing. You need dedicated physical therapy and nursing staff available 24/7 to execute early mobilization, often on evenings or weekends. It requires capital to develop the software for the audit system. And crucially, there's often a fatal lack of effective coordination across disciplines.
How so?
If the surgeon demands early feeding, but the nursing staff are unavailable to deliver the diet, or the anesthesiologist keeps the IV pump running liberally, the pathway just breaks down.
And if the pathway breaks down, if compliance is inconsistent, then the entire multimodal benefit, that crucial synergy, is lost.
It's completely lost. The difficulty in achieving consistent compliance across all protocol items is perhaps the single largest barrier. You can't cherry pick. If an institution has 80% compliance with early feeding, but only 30% with opioid-sparing analgesia, the patient outcome will be much close to the old model. The pain management failure negates the benefit of the feeding. Success requires every item to be performed consistently.
This brings us back to the audit. If the audit system is so critical, what happens to institutions that consistently show low compliance? Is there an external penalty, or is this purely self-regulation?
Currently, it's primarily self-regulation, driven by professional quality standards and the pursuit of optimal outcomes. But that audit system is rigorous. When an institution shows low compliance, say in timely catheter removal, the audit highlights exactly when in the patient journey the failure occurred. Maybe it's usually on the night shift.
So you can pinpoint the problem.
Exactly. It forces the multidisciplinary team to address the specific workflow or staffing issue, not just generally try harder. The pressure is internal, driven by benchmarking against global leaders who are achieving complication rates that are sometimes 30% lower than non-compliant centers.
So what are the structural necessities, the non-negotiable requirements, for a program to move past these barriers and be truly successful?
A successful program needs 4 things to sustain compliance. First, a dedicated, empowered, multidisciplinary leadership team to champion the program and enforce the standards. Second, comprehensive staff training and continuous re-education, because staff turnover is high.
Okay.
Third, the actual physical ward environment has to be restructured to support rehabilitation. Things like easy access to walking paths, minimal patient lines, and a culture that celebrates mobility. And fourth, that sustained, regular audit cycle must be transparent and used to enforce accountability.
It really sounds like the audit is what translates good intentions into enforceable, standardized action.
It is the mechanism of continuous improvement. Without that feedback loop, ERA is just a set of suggestions on a piece of paper.
Let's pivot now to the final payoff, because this is what justifies all that cultural and institutional transformation. What are the validated, undeniable benefits that ERAS delivers when protocols are followed rigorously?
The benefits are a clear, overwhelming victory for patients. When pathways are adhered to consistently, ERAS delivers fewer overall complications, specifically lower rates of pneumonia, wound infections, and deep vein thrombosis. This results in a significantly shorter hospital stay, often cutting the length in half compared to historical controls.
And what about the recovery metrics that matter most to the patient themselves?
Patients see a faster return of bowel function, improved cardiopulmonary recovery, and higher overall patient satisfaction scores. They feel less pain, less lethargy, and they get back to their normal activities sooner. It moves the entire experience of major surgery from a debilitating setback to a rapid, manageable recovery process.
So to bring it all home, let's just reiterate the key element of success.
Success in ERAs relies entirely on rigorous adherence to those standardized multimodal pathways. It requires the active, conscious avoidance of those outdated interventions, the routine drains, the nasogastric tubes, prolonged fasting, that actively impede recovery. It's a commitment to maintaining physiological stability and minimizing surgical stress through the application of evidence-based science at every single step.
This deep dive really shows that enhanced recovery after surgery represents a profound commitment to evidence-based practice and truly patient-centric care. It's a sophisticated system designed to strip away the tradition that slowed people down and replace it with science that gets patients back to their lives faster, safer, and with dignity.
What's fascinating here is not just the medical achievement, but the framework itself. This system of excellence is fundamentally defined by its multidisciplinary adherence to standardized pathways, and critically, by those sustained mandatory audit mechanisms. That is how they maintain and improve quality.
Which leads to our final thought for you, the learner, to consider. ERAS is a highly complex, high-stakes medical field, yet it found a way to dramatically reduce uncertainty, error, and cost by rejecting historical dogma in favor of a continuously audited, evidence-based, multimodal protocol.
So think about what other complex systems, non-surgical, maybe business logistics, large-scale policy implementation, or even complex engineering projects, could achieve similar leaps in efficiency, safety, and accountability if they adopted this exact model.
Identifying the traditional dogmas that hinder progress.
Building a standardized multimodal path based purely on evidence, and then enforcing compliance through rigorous, continuous, transparent audits. The ERAS blueprint might be the most valuable takeaway of all.
Absolutely. Thank you for joining us for this deep dive into the modern surgical landscape. We'll see you next time.